Welcome to the Healthy Human Revolution podcast. I'm Dr. Laurie Marbas, and today I'm so honored to welcome Dr. Judson Brewer. How are you?
I'm good.
Well, we are so excited to hear from you. Everyone, you're going to learn a lot more about him. I typically do a prologue to the interview, so they'll hear more information about your experience. But you are basically what we describe as a mindfulness, I would say a guru, and you're a psychiatrist, you're an MD, PhD, which I don't even know how many years that took. More than I care to think about. And but also habit change and using mindfulness for addiction. And that's how I first came across your information, looking for help with patients with smoking. And I was so intrigued. But can you tell us a little bit about your background, how you came into mindfulness, medicine, and all these amazing things? There's so many questions I have to ask you.
Sure. I'm kind of an accidental tourist in the mindfulness field. I got into this just personally because I was pretty stressed out right at the beginning of medical school. And it seemed like a perfect time to try something new in addition to trying medical school. So my first day of medical school, I started meditating. It just seemed like a good transition time. And to be honest, for the first 6 months or so, I fell asleep. I'd listen to these cassette tapes of meditation and fell asleep for most of the time, but then started, getting the hang of it a little bit more, staying awake, and then even learning that, wow, I could meditate during boring medical school lectures.
And so tell us and we kind of mentioned this a little bit before we started. What does it mean to meditate? Because for some people, like if, you try to sit there and you're like, like you said, you listen to the tapes and they say, be mindful of your different parts of your body, and your mind wanders and you hear a noise and you're just like, ooh, a squirrel, something like that. What does it mean to meditate? And what does it mean that you suddenly you over time were able to change? What is that? What's occurring, I guess?
Yes. So there are many ways we can unpack that. And I would answer that very differently now, over 20 years later, than what I would have answered back then. I had a very different concept of what meditation was. And there's a lot more that's known about it, both pragmatically and scientifically as well. So what I would say now is meditation and this meditation can take many different forms, but it's a way to help us start to train our minds to be present in the present moment, as in notice these habitual tendencies of our minds to be lost in thought, like the squirrel, distracted here or there, right. Whatever that proverbial squirrel is, to notice that push and pull and to bring some balance through simply being with the experience, through being aware of it. So what I would say is these meditation practices help train our minds to learn when they've wandered, to learn when they've gotten caught up in a thought or an emotion, or avoiding something or a craving, and to be able to see that we can actually be with whatever it is, rather than running away from it or getting sucked into it.
So it's more than just the practice of sitting in a quiet space and meditating. It's actually using it in other parts of where you're actively involved in something, but you've trained your mind to react differently.
The meditation can help us start to see the habitual tendencies of our minds. And so this is actually where I started learning how this applies to behavior change. If we don't understand how our minds work, if we don't understand these habitual tendencies to get lost or, in thought, or to avoid unpleasant emotions, or to do this or that, it's like this black box. We're going to not know where to even start. But if we have a space where there's not a ton of stuff happening at once, like sitting down during meditation, we can actually start to use that time to map out how our minds work. And that's what often meditation helps us do, is to notice, oh, here's this, and this is linked to this, or every time I had this thought, I had this emotional reaction. As we start to map out all of these different, I think of these as habit loops, following on Charles Duhigg's work around habit formation. That's really, I would say, a tremendous amount of what meditation and mindfulness training is to help us really understand how our minds work, because they will naturally incline themselves away from unhealthy habits. That's the hypothesis that I would put forward.
So it's almost like you're starting out, you're kind of tuning into your own radio, right? So you're like listening finally, and I guess adjusting so where you can actually understand. And can you explain a little bit? I mean, I'm a huge fan of Charles Duhigg. I've emailed him back and forth. And so he probably thinks I'm one of his stalkers. I'm like, but I have so much information. I need to ask you. I'm going to use this with patients and stuff. But with that, can you describe what the habit loop is and how did you decide to interface these two things together?
Simply put, I think of what are necessary and sufficient conditions. And so there are three aspects of a habit loop. You need a trigger, a behavior, and a reward. And this was, I don't know if Dweck talks about this in his book, but this was actually set up evolutionarily as a way to help us remember where food is. So it's actually the most scientifically validated learning process known, full stop. Mm-hmm. So if we're on the proverbial savannah foraging for food, we see a food source, we eat it, and it has calories in it. This signal comes from our stomach and spritzes dopamine in our brain that says, remember what you ate and where you found it. So the trigger is, seeing food, the behavior is eating the food, and then the reward from a neurologic standpoint is getting that dopamine spritz that lays down that context-dependent memory. We call it reward now, but I don't think our bodies think of it as reward. They think of it as survival. But if you fast forward that to modern day, for example, when, food is plentiful, our brains are still behaving this way because this is how our brains work. And so we start to learn things like getting stressed out. And if we eat chocolate, we feel better. And so there's that trigger, of stress. There's the behavior, which is stress eating, right? That's different. It's interesting. Physiologically, when we have physiologic stress, blood gets shunted away from our stomach and we're not hungry because our job is to run away so that we can survive to eat in the future. But somehow in modern day, our brains have learned, that dopamine signal of feeling good. And a lot of this probably has to do with, the refinement of sugar and getting, these hits of sugar and carbohydrate that send these big dopamine surges to our brain so that it acts more like a drug rather than something that's, a source of calories to find later.
Wow. So it's a combination of the things. So we've got the food everywhere, but it's not just regular food. So I wonder if we'd have the same effect if we just had whole foods available instead of the hyperpalatable processed Franken foods that are available throughout. I don't know.
Well, you tell me, did they show pictures of broccoli on billboards that say craving?
That's interesting though, because I work a lot with parents. I have 3 kids myself, they're all grown now. But the interesting thing is that there was, I don't know if you're familiar with this research, but when they actually just took kids in a regular school lunchroom, and they didn't put any special type of cartoon, but they put it like a carrot, and he was like a little superhero or something, just a regular character. They saw a significant rise of eating with that. So it's interesting, you're associating different things with food, and it goes back to that habit loop and they're like pleasure and seeing that. I don't know. It just seems very interesting. So
it is. And I don't think that's a coincidence.
I think that we just need to take a few lessons from the marketers and how they got us to eat poorly and turn it around.
Yes.
How did you decide, because you're a psychiatrist by training, and then you went into your PhDs in what category?
It's actually in immunology, but now I would consider myself more of a neuroscientist than immunologist.
Okay. Wow. That's fascinating. Okay. We can even go down that track. Immunology is really cool. But now you have some really interesting stuff. So you also have the Craving Mind, your book that came out in February, I believe, of this year.
The hardbound came out in 2017, and this paperback came out this year.
Okay, great. And so that would be, I'm working my way through. I haven't received it, so I had to do the Kindle version. But really cool stuff there. And I encourage people to check that out. But can we talk a little bit about the smoking? Because I think this is really fascinating, because I've actually been working with a patient for about 2 months now with your app and a few other things, and it's working really well. So if you can, coming from using this in practice now, and that's why I'm a big fan, can you explain what it is, why it works, and kind of explain that a little further?
Sure. And this was based on a bunch of research that I did back when I was an assistant professor at Yale, just looking to see if mindfulness training would work to help people quit smoking. And I got into this because it's interesting, my PhD being in immunology, I was interested in the stress immune interface when, like, why do we get sick when we get stressed out? And I was just practicing meditation on my own. And then when I went back to my 3rd and 4th year of medical school and was on the wards, I was noticing that my patients with addictions were speaking the same language as the stuff I'd been learning in my meditation practices. And I was thinking, this cannot be a coincidence. This is way before mindfulness got popular. So there wasn't really much out there. And I decided to shift my career into studying mindfulness because I wanted to learn neuroimaging and neuroscience. I wanted to learn clinical studies. And I was really fascinated with the addictive process, especially because, like, these Buddhist psychologists had discovered this process thousands of years ago. So we basically brought these principles into play and designed some clinical studies. In my first smoking study, we actually found that mindfulness training was 5 times better than gold standard treatment. And when we started looking mechanistically at why it was working, it had to do with these informal mindfulness practices that we were teaching people. So we designed the Craving to Quit app based on that, our clinical data and our research. And it actually had taught me a lot of things that I'd made some assumptions that were actually not true, and we could update it based on the data. But basically, the program works by helping people really see what it actually feels like when they smoke, which is really important because, people come to me and they come to you because they want to quit smoking, but they haven't quit. In our first study, people on average have tried to quit 5 to 6 times before. So we start by having them simply pay attention as they smoke, because that taps into their direct experience as compared to their cognitive thinking mind that says, oh, you shouldn't smoke. The "oh, you shouldn't smoke" part of your brain, the prefrontal cortex, it goes offline when you get stressed out. And, oh, stress is a trigger for smoking, right? Mm-hmm. So that just inherently is problematic. And it's probably why the cessation rates currently are 5%, at 1 year. When people try to quit smoking, the likelihood they're going to stay quit is 5%. So we said, well, let's take a different approach. Let's actually tap into these reward-based learning processes and have them pay attention, so they don't have to do anything. They don't have to force themselves not to smoke. We say, go ahead and smoke as much as you want, but pay attention as you do. And universally, what they discover is smoking tastes like shit. Pardon my English.
I love
right?
it.
So their brain, there's a part of our brain called the orbitofrontal cortex. It holds relative reward value. And I think of it as the bigger, better offer part of the brain, the BBO. I don't know if you've heard that term before, but the idea is our brain is always looking for that bigger, better offer. What's better than something else? So for me, I don't know if you can relate to this. For me, it's chocolate, right? So my brain knows that 70% chocolate is much better than 40% chocolate. I won't touch milk chocolate, even if somebody shoves it in my face. No thanks. 70% is better than 40%. 85% is even better. And then you get into the brand, I like this brand over this brand and whatnot. But my brain has this whole hierarchy of, this chocolate hierarchy. And that reward value is stored in the orbitofrontal cortex. Well, that's happening all the time. Our brains are constantly looking. They're saying, what's better? I have this option. What's better than this? So the first thing we can do is help our brains see this and see how unrewarding smoking actually is. It decreases that reward value. And that's critical because reward-based learning isn't based on the behavior itself. It's based on the reward. So if the reward is not that great, we start to become disenchanted with the behavior itself without having to force ourselves. It's kind of, I think of this as like, you take your kid to the mall and she or he sits on Santa Claus's lap, and you're like, oh, great, I'm going to get the Christmas list and all this. And they reach for the beard and we're like, no, right? Because as soon as they pull in Santa Claus's beard, the gig is up. You can't go back and be like, hey, don't, just forget that Santa Claus is real. It's over. And the same thing is true in our brains. When they start to see really clearly that the cigarettes don't taste very good, you can't undo that. I had a guy who'd been smoking 40 years and he's like, how did I not notice this before? Right? And on average, 40 years at a pack a day, that's 300,000 repetitions, roughly.
Oh my gosh.
So
I never did that.
Yeah, it was that habitual for him.
Oh my God.
So we have to tap into the oldest parts of our brain to be able to break these habits. Otherwise, the prefrontal cortex, it's a goner. 300,000 versus 300,000 push-ups that our brain just did, forget about it, right?
Right. Absolutely.
So that's the first step, is
Okay.
helping people simply pay attention to what it tastes like, what it feels like, what that super heated smoke feels like as it's going in their throat. And I can see from
Right.
your expression, it doesn't feel very good.
Well, just being around secondhand smoke, I downloaded your app. It's so funny. I've never smoked a day in my life, and it keeps telling me, today we suggest you smoke 0 cigarettes. But I upload it because I show it to patients. And anyway, go ahead. I'm sorry.
So the interesting piece there is, as they start to update that reward value, this opens up space so their brain can say, okay, what's better than this? And it turns out there are a lot of mindfulness practices that actually feel pretty good. So we can train people to get curious about what the sensations of craving feel like, so they can ride those out. And those practices specifically correlate with the likelihood that we can decouple the craving and the smoking behavior itself. And we've published several papers on this now. But the idea is it opens up the space when they're disenchanted and they're motivated. So, wow, this isn't very good. I want to do something. We can teach them these simple practices where they can ride out the cravings in the moment that they come. And then they can start to decouple that reward-based learning association between, stress or meal or whatever and smoking, right? The trigger and the behavior, simply through hacking that reward-based learning system. And if you're interested, we can talk more about, we actually found that this applies to many other behaviors as well. So we translated this into working with stress and emotional eating, and we developed this app called Eat Right Now, where we've got a 40% reduction in craving-related eating. We even did a study with physicians when we developed our anxiety program called Unwinding Anxiety. So we can talk about that as well, if that's interesting.
Yeah, no, I've sent people to it as well.
Okay, so but back to your core question.
Yeah.
The idea is, if we can really help people understand how their minds work, if we can really help them map out this reward-based learning system and then hack it, this may lead to long-term benefit. We actually just finished a study where we do neuroimaging. So we can we put people in our fMRI scanner, show them pictures of smoking cues. It lights up a part of their brain called the posterior cingulate cortex. It lights it up like a Christmas tree. And then we give them the Crave and Equip program or a well-matched active control. We use the National Cancer Institute's Quit Guide app as an active comparator. And then a month later, we scan their brains again. And what we found was that we can target specific brain regions with mindfulness. So we discovered these brain regions previously looking at experienced meditators. We could then take that in a hypothesis-driven way and show that this app specifically decreases brain activity in that region that's associated with getting caught up in craving, and that decrease correlates with a reduction in cigarette smoking. So we see this very strong correlation, and we see zero correlation in the control group at all. It's amazing. So we actually can map out the behavioral effects, we can map out the neurobiological mechanisms, and surprisingly, we can actually deliver this through an app, which I was a little skeptical when we first started doing this work, but now that the data are pretty robust, it's much more convincing to me.
So, and then have you done, longevity studies on use of app in like a year out or 2 years out, or how long is the success rate, or where is that at?
It's a great question. We've just applied for NIH funding to look at those. So with our mechanistic study, we looked a month out because that's what our neuroimaging paradigm worked with. We've got some other studies running where we can look 6 months out. Our first study that had the 5 times better quit rate, we looked 4 months out. So that's decent, but I think gold standard is 6 months. So we really need to look at those long-term data, see how they hold up.
So can you explain a little bit about, for those I have a lot of physicians in the audience, but explaining what a functional MRI is so that people understand what that actually means and how you're able to see inside the brain what's going on?
Oh, sure. So basically, typically we think clinically MRI is to help, give us structural information to see if somebody, has a brain lesion or a tumor or a bleed or something like that. with functional MRI, we can look at what's called BOLD signal, which is blood oxygen level dependent signal, which basically means it's a surrogate marker of neuronal firing. So we can do these different mathematical sequences that don't look at anatomical structure per se, but they look at specific anatomical structures and can determine whether they're more active or less active. And so that's why it's called functional MRI. So we can basically look at, brain activity using functional MRI.
It's fascinating that the brain, I really should have gone into psychiatry. There's many fields I get intrigued in, but 3-pound mass uses up 20% of our glucose that we consume because it's so metabolically active. So I think that's fascinating.
It is.
Can you talk a little bit, because I have, when you look at the prescription rate of medications for antidepressants, anti-anxiety medications, I constantly, whenever I see patients if I see a cold or if I see someone for the flu or their hypertension, their diabetes, they're always listing, there's some type of medication there that's an SSRI, medications for that. And it's always, anxiety tends to be the highest one, actually more than depression in my personal experience. That's just anecdotal. Can you explain a little bit about the unwinding anxiety and what you're describing is the mindfulness and how that works? Because it's outside of an addiction, I would think, or is it a similar type of mechanism? I don't know.
Or is it? Yes.
Or is it?
So certainly there are genetic predispositions that folks have that make them more anxious than others. So, but we don't have a lot of control over our genetics right now. So that piece, I just want to acknowledge that, but place that off to the side. There's actually been a lot of research showing that anxiety can have learned elements to it. There's a guy, Borkovic at Penn State, that studied this for decades, where basically a trigger can be a negative emotion, let's say fear. Then we have this behavior, and worry thinking is that mental behavior that acts as a negative reinforcer because it feels less bad than fear itself. And it also can give us a sense of control or distract us from that unpleasant emotion itself. So if you think of fear being the trigger, worry being the behavior, and then a feeling of control or distraction or whatever being that quote unquote reward, that starts to set this up as a negatively reinforced habit loop. The problem is, as our brain starts to become wise to the fact that worry doesn't feel that good in itself, it starts to become less rewarding, but we're stuck in the habit loop because our brain says, oh, fear, worry, and then worry, oh, worry. And then we just start ping-ponging between one worry thought and another. I think of this as going over the event horizon in this black hole of anxiety. So anxiety itself has shares qualities or shares behavioral or mechanistic pathways with any other learned behavior. And all addictions fall into this type of habit loop formation. So when we learned that, I said, well, can we actually develop this unwinding anxiety program based on what we've been learning from our smoking and from our Eat Right Now program? Because we were seeing good results with both of these. And in my opinion, anxiety is even harder to conquer. For example, one of our pilot testers, I remember her writing me an email saying, I feel like she was so identified with anxiety. She said she felt like this was deeply etched in her bones. Right? Wow. This blanket of, she wakes up in the morning and she's anxious and she's just anxious all day. And so to me, this was a great challenge. Can we, if we can, I thought smoking was tough to work with. It is. I thought eating was tough to work with because you don't have to smoke to survive, but you do have to eat. And so there were challenges there. And then we're getting these 40% reductions in eating. And so we're like, okay, we can make some headway here. Can we actually help people unwind their own anxiety? So I took the most recalcitrant population I could think of, which is people like us, physicians, right?
We are horrible.
Yes.
We are horrible people. I'll tell you.
I'll speak for myself. Yes, I agree.
I have some that are patients. I can see that.
So we have this martyrdom mentality that we probably learned in medical school. We have this armor up, like don't show weakness, don't sleep, don't have to eat, don't have to do anything, which is ridiculous, of course.
We're not human. We're immortal.
Right, right. Which is
Exactly.
why we have much higher burnout rates than the
And
general
suicide rate.
population, and suicide and addiction and on and on and on and on. So I figured if we could actually make headway with physicians, then we know that this program will work, with the general population. Let's start with the worst
I'm
population.
like, you're really putting some burden on yourself. Okay.
Well, I think of this as, it's this go big or go home mentality that one of my PhD mentors used to say. It's like, if you're going to ask a question, ask it.
Then everything else will be easier.
It's absolutely. And you learn a
Very
lot,
true.
you
Absolutely.
learn a lot from it. So we asked a simple question, like, could we get anxious physicians to use a program? Because we also, and I'll speak for myself, say, oh, I don't have time, I'm busy, I'm not, hold this, this air of busyness as part of our persona, right? So, I'm sure many physicians can relate to this.
I
So,
can. Yes.
so the bad news was this was the easiest study that I've ever recruited for, because when we sent out one email, this is at our academic medical system, in our network, and we got so many people, so many physicians who screened positive for anxiety and wanted to use the program. We didn't have to do any other recruiting.
Wow.
It was, I even had a friend who came to me and said, Judd, I didn't qualify for your study. And I said, that's a good thing. You weren't anxious enough.
Wow.
So high prevalence. And, when we looked at the baseline data, it's like, some huge amount, like 50 or 60% of these folks had moderate to severe anxiety. Half of them, I think, had, reported burnout, at least on a weekly basis, a quarter of them daily. So, it's tough. This is a real thing in terms of physician anxiety and physician burnout, and the two are linked. Mm. So we just asked the question, can we get them to use this program, and will it reduce their anxiety? So we looked at, the GAD-7, this clinically validated generalized anxiety disorder questionnaire that many of us use
on a daily basis.
Yes, tracking our patients.
Yeah.
And we found, after just 1 month of people using the program, we found a 50% reduction in anxiety, which blew my mind.
Oh.
We'd seen some in pilot data with a general population. We'd seen reductions like that in folks with moderate to severe anxiety, but with physicians, I was blown away.
That's awesome.
And here's the even better part. We didn't mention the word burnout in the program at all. And we got a 50% reduction in burnout, 50%, roughly 50% reduction in callousness. The folks reporting that they're feeling callous toward others at their job and toward their patients. So the hypothesis was that if they could learn how their minds work and they could work with their anxiety, they could also learn to see other habit patterns that include things like feeling helpless at, being able to make change at work, being callous toward their patients, and how unrewarding those things are, so that their brain starts to change that as well. And that's at least my guess as to why we're also seeing reductions in these other symptoms, because we didn't teach them this stuff at all. So that's, and it goes along the same framework as our other programs. They get 10 minutes of training a day, in the moment exercises, online community if they want to use it, although I don't think a ton of the physicians used it. All the resources that they would need to be able to fit this into their already busy life. Because that was the other piece, is we can't ask physicians to do a bunch of extra stuff, because then it's just going to feel like it's more burden.
More anxiety.
Yeah. So they can sit on the toilet for 10 minutes a day, and they might as well, or whatever. They can be, and I know people
speak only truth. I like it.
Well, for some people, like, the only quiet they have if they have a bunch of kids or whatever is like in the bathroom in the morning.
I'm sorry, if you're a mother, that doesn't qualify either. Their little fingers when they were little. Yeah, no, I get it. That's, I don't recall actually. And even now you worry about your children, even though they're all grown up. I actually have one of my kids is a medical student. She's a second year and she's actually engaged to a medical student. So I'm like, you guys didn't learn. But yeah, I think I have some questions. So as you were talking about this, I really like positive psychology and spinning up things. I like trying to prevent this before you, or so I was in the military, I was active duty, I was deployed overseas. And so I have seen a lot of stuff. And I'm curious, what do you think about like resiliency training? Because it occurred to me that with what you're describing, if we can get people taught this, like, or even medical students before they're physicians, to teach it to themselves and do like you did, you started bringing this to your practice, or to teach our soldiers, this is what this is, and then helping them when they are put in very stressful situations to sit back and maybe help decrease, rates of PTSD and things like that. Is there any thought on that, or have you explored that, or know of any research into that?
I actually wrote an entire chapter in my book on training
Is this the
resilience.
book that I'm working on
Yeah.
reading? Because
Yeah.
they're
In the
okay.
Craving Mind, there's actually a chapter on training resilience.
Oh,
So
okay.
briefly, and I actually use examples from physicians in the medical profession for this, because I think it's a beautiful example of, this term, you probably know the term empathy fatigue.
Oh yeah.
So so just think about this. If our patients are coming to us, they're usually, unless it's a wellness check or something, but if they're coming to us because they're sick, they're suffering, okay? And if we are being with their suffering, let's say 40 hours a week, that's a lot of suffering that we're with. And if we're taught to empathize with our patients, and the idea is to put ourselves in their shoes, then ipso facto, we are suffering, right? If we're really putting ourselves in their shoes. So of course we're going to get burnt out, and we're going to feel like we have to distance ourselves, because that's absolutely unpleasant, and it's not, that's not a long-term solution.
Right.
Yet, this is all because we take things on, or we take things personally. And this is actually where mindfulness comes in. It helps us see where we are becoming identified versus where we are just being with. So I love the differentiation between empathy and compassion. And I think this is starting to be talked about more in the medical profession, where compasio literally means to suffer with, but it doesn't necessarily mean to suffer oneself.
Right.
So what mindfulness helps us do is to see when we are taking on the suffering of others versus suffering with. Because we've even mapped this out into the neural structures that are actually the same structures that get activated when we get caught up in craving. When we get caught up in fear or pain, even emotional pain, there's this contracted quality that's like, oh, this hurts, right? That it's actually part of a self-referential brain network. It's called the posterior cingulate cortex, is the brain region. That brain region is a marker of the experience of the experiential self, right? It's not necessarily the conceptual self, like I'm Judd. There are other brain regions that are involved in that, but it's this marker that says I'm holding, this is me experientially. So that when that gets activated, we go into self-protective mode because it's painful. It's painful to get contracted. It's painful to feel pain, literally. So what mindfulness helps us do is to see that is that part is optional. And we can be with suffering without taking that suffering on. And we can truly really be able to be in the shoes of our patients without suffering. And in that instance, when we are with suffering but not identified with it, if that makes sense, there's this natural compassionate response that comes out. And this is, I think, the beauty of medicine. When we are at our best, we are totally in there 100%, understanding where our patients are coming from, being able to, muster our resources in a way that doesn't fatigue us, because compassion actually is energizing. It's not about us. We don't have to protect ourselves. We don't have to spend all that energy holding up that burden of protecting ourselves or taking on this patient's suffering. So that's actually a lot of what I wrote this chapter about. But there's good data showing, there's a paper study published in the Journal of the American Medical Association by Mick Krasner and Ron Epstein, probably almost a decade ago now, where they actually taught primary care physicians mindfulness. And they found a significant reduction in burnout, in all these measures of depersonalization and things like that, because these physicians were learning not to take on that burden. They were also learning that they could be with their patients even in a more connected way because they didn't have to protect themselves, if that makes sense.
Interesting. So why isn't this taught in every medical school?
Medical schools are slow to change. So there are medical schools that are starting to teach these types of things. Here at Brown University, they are incorporating mindfulness training into the curriculum. And there are other medical schools that do this as well. So I think that, that we really don't have an option not to teach these types of things. One, students can learn how their mind works. Two, they can learn how to not get caught up in anxiety habit loops, for example. So imagine helping students develop resilience skills before they take step one of the boards or before they go into their exams, so that they can actually, be at their best as compared to be freaked out.
Right.
And take those good resilience skills into third year, into residency, into beyond residency. Boy, what a wonderful workforce we would have.
So I have a kid that I told you about. It's a medical school. She's going to take her step one next summer. Mm-hmm. And so where would someone like that, or who's going to be entering into a stressful situation, begin to even learn about mindfulness? Like they're like, okay, that sounds great, but now how do I start?
It's a great question. We are exploring how best to do this. And so, for example, I'm supervising a medical student who's doing his capstone project now, looking to see if we could use simple things like this unwinding anxiety program in first year medical school. So we introduced this as a resilience training as people start medical school, and explore how do we best incorporate something like this even into the curriculum. It could be part of the understanding cognitive neuroscience. It could be part of psychiatry. It could be part of a bunch of things. But one thing we're testing is, if we introduce it early, will this help develop these resilience skills at the time when they're open to learning, right? Introducing it right before boards, probably not a good idea, because they're freaked out about their boards. They're not going to have any capacity to learn something new. Mm-hmm. And their brain is going to say, why am I doing this? I should be trying to memorize minutia or whatever, whatever I do for boards.
I love this. It's very true. Okay. Well, it's funny because for me to get through medical school, my kids were 5, 3, and 10 months when I started. And as a first year medical student, because I'd stayed home for 6 years and had my kiddos. And for me when I got through pharmacology, and I had a grandmother who lived with us as well, my husband, and she ended up with breast cancer. I mean, I was maxed. And so the interesting one is I found drawing cartoons, believe it or not, like visual mnemonics is what we call them. And I literally survived medical school by drawing myself through it. And I think it kind of reinforced, it was such a craving. I almost craved drawing then, because that's how I dealt with the stress. Mm-hmm. and it blossomed into a great learning tool, and it helped others, and it was really cool. But I look at these young physicians and residents, and it I don't know if you know the work with Pamela Weibel, Dr. Pamela Weibel.
I don't think so.
She works a lot with families of residents and physicians who've committed suicide, and it's just heartbreaking to see that. And I'm always, racking my brain. Well, what can we do? I do enjoy lifestyle medicine, because it's teaching things like this to people, and seeing people thrive is so invigorating, and it's highly addictive. I call it, because I'm always encouraging good habits of eating, call it veggie crack. So it really is. If I get people to eat more vegetables, they feel better. It's a small thing, but you do feel better. And it's a very interesting thing. This is fascinating.
And that even hacks that same reward-based learning system, because natural foods actually, our bodies feel better. So if we can really tap into that reward and compare it to the non-reward that comes from, the designer food or the engineered food, our brains start to see that much more clearly.
Interesting. And I found that one thing that works really well is I have patients, kind of like a medical symptom questionnaire, where before we even get them to tremendously change their diet, because I work a lot with nutrition, quite a bit. And what they do is they forget, oh, I had aches in the morning and I had brain fog and I was just always tired or constipated, joint pain. And then what happens is it's almost it's a sort of a mindfulness
Yeah,
trick, I
you're
would
helping
say.
them become aware of the cause and effect.
And then
Absolutely.
we redo it in 30 days and they go back and they go, oh wow. Because otherwise I think they would have forgot. It is interesting.
Hmm.
I never really thought about the different things that I found to be successful are basically bringing it to their attention and helping them work through what their goals are. Interesting. I have another question. I know I get to talk to you all day apparently, but the so when I have forget people who are usually when people call me, I'm doing telemedicine now. I did regular practice for many years, but I did telemedicine for the last year, and I've really enjoyed it because it's allowed me to see people all over the country. But they're calling, they have bronchitis, they're smokers, the typical patient. And what I found is that you're like you said, they've tried multiple times, they quit. Sometimes they don't feel well, and that's a good time to intervene and saying, hey, let's work on stopping. But I found that if they haven't already made in their mind decision that I'm not a smoker versus I'm trying to quit, what is that difference? Is it alignment with beliefs, or it's like those who say like I'm not a smoker, I'm not going to smoke. It's there's something that happens. Where is that? Is that just another mindfulness component?
I wouldn't say that that is necessarily a mindfulness component. I can certainly see how that would be helpful because it could create some cognitive dissonance. So if
Mm,
somebody says, I'm not a smoker, and they've got a lit cigarette in their hand, their brain says, wait a minute, there's something, what's going on here?
right,
And so at
right,
least it gets them to start paying attention and could help them bring awareness a little bit more. The mindfulness practices are really about helping us see that cause and effect relationship really clearly. Like you were talking about the benefits of eating healthfully.
right.
If they're not seeing those cause and effect relationships, it not to say that these other practices can't work, but that's not utilizing our best weapon, so to speak, which is
Right.
reward-based learning.
Wow. So where do you see this going then? Where do you see your studies and your practice, or where would you like to see it end up? Like what would be like all those years of work that you've been doing and those revelations that you've had, where would you like to see it?
That's a great question because we've been doing this work for about over 20 years now,
Wow.
and I feel like we're just at the beginning. you know, there, and we've certainly discovered a lot and made a lot of links, and have found, these things are pragmatically useful. We're seeing large reductions in these symptoms and behaviors. Yet maybe I'm just never satisfied. So what I'm looking to do now is to even personalize these trainings even more, where we can take certain behavioral tendencies that people have and see based on, and this also links into operant conditioning, where some people are more, they lean more, you think of it as the fight, flight, freeze. So we have tendencies where some of us lean more toward fight, some of us lean more toward flight, and some of us lean more toward freeze. And this is actually described in the 5th century by a commentary on the ancient teachings of the Buddha. It's called the Path of Purification.
Wow.
And to my knowledge, it's the first example of personalized medicine, because what they would do is they would observe people, how they acted, how they ate, what clothes they wore, and all this. And then they would prescribe specific meditation practices based on their types. And so we actually made a modern day version of this, did all the validation and whatnot. It's called the Behavioral Tendencies Questionnaire. People can look it up on PLOS One. But the idea is to be able to take somebody's strengths that they already have, their own tendencies, and be able to personalize these trainings so that they benefit from them even more. So, on a population level, we're seeing pretty good results. I think we could jack that even more by personalizing these trainings so that people come in, they know their strengths, and we can train to their strengths. We can lean in there, and we can utilize those strengths so that they learn these things even faster and more robustly.
Hmm. So that could be significant. I mean, I think about lifestyle medicine, telemedicine as well. What a great tool to use.
Personalized medicine, coming through your phone.
Yeah.
So I
I
think
mean,
of these, what Cornel West calls our phones are weapons of mass distraction. So, so if
take
they're
on.
here, if they're already in our pocket and
Right.
distracting us, we might as well use them for good as compared to whatever we get distracted for distraction.
I almost think it should be even more than just like, you get a little reminder or a buzz, but actually have them call and have a recorded voice and saying, hey, we're calling you to remind you of this. Facebook Messenger, emails, all of that. That is really interesting. I have so many ways I could go through this, and I'm trying to figure out which rabbit hole to dig down in the last 10 minutes here. Um, I would like to know a little bit more about what you're doing currently. Can you tell us about the Claritas Mind Sciences and what you're founded there?
Sure. And the company just shortened its name
Oh,
to Mind Sciences. So it came from
okay. No
the
more Claritas.
Facebook, went to Facebook. So following that path of simplicity, the company was actually founded back when I was at Yale, because somebody came through and was looking at the work we were doing and was really impressed with it and said, I don't want this to languish in the ivory towers. And so I'd really like you to get this out there and help people. And I was certainly on board with that because that's kind of dedicated my life to trying to be of service.
Right.
And so we started developing these programs and these digital therapeutics 6 years before the term digital therapeutic had even been invented. So we were actually early in the game, and took the basic question of, if this learning pathway is set up to help people learn to form context-dependent memories, they don't learn to smoke or to stress eat or to get anxious in my office. So can I package my office and bring it to them? And so we were taking our evidence-based training, and we started developing, these apps that we were talking about, so that we can give them short, bite-sized pieces, animations, videos, things that would really engage them, so that we could actually reach people in their own context. So we can deliver training when people, we think of this as a point of care, or not really point of care, but on demand, training.
Mm-hmm.
And people learn best in their own context anyway. So this might even be better. So the idea was born out of that need, where we had good efficacy. We needed a better way to disseminate and also to maintain a very high fidelity. So we're finding that it's hard to disseminate in-person training, both at a scalable, it's hard to scale that, and it's hard to train people to deliver it effectively with 100% fidelity, but even with good enough fidelity. Therapists are good at being therapists, but they're not necessarily good at following a manualized treatment. So we said, let's take all those variables and fix them so that, we know exactly what people are getting. Let's deliver it to them where they don't have to get childcare. They don't have to come in for an appointment, and they can get this on a daily basis, because that's how we form habits, is daily, 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 daily. We think of the short moments many times, and we use that a lot in our programs. A short moment of mindfulness helps you develop a healthy habit over time as you do it more and more and more and more. Right. So yeah, Mind Sciences was born out of that to just help move this stuff into the marketplace, because an academic medical center isn't the place for that. So my lab partners with Mind Sciences. They develop the app-based training, and then my lab can research it, and it's been a really good partnership in that way.
Cool. Because I would think, so I see that, so you have the Eat Right Now, the Unwinding Anxiety, and the Craving to Quit. And those are the 3 programs that you have currently, correct?
Yes.
Okay. So this is coming from my end of thinking, and I'm going, geez, if I had this. So instead I'm having to tell my patient, okay, I want you to go download this app, and I literally have it on my phone. It's like the little wave guy. I want you to go download, I want you to use it, come back to me. But if I could just click a button. So I work for Doctor on Demand, and one of the telemedicine folks, very progressive, very good. It's a good place. And if I could just click boom, and it's delivered to them and saying, here, download this app. Just like I can order labs, I can order medications. I think that'd be phenomenal.
I think that's a great idea. So I think that's probably the next generation as we start vetting these digital therapeutics. So all of ours are evidence-based, but there are many out there that aren't. And so folks like Doctors on Demand have to vet, what's worth telling their patient to do, and then figure out a prescribing and we think of it as a reimbursement thing as well. But we should, this would be a great
offline conversation.
Yeah. And this type of thing is the next generation, where you've just described minimizing those hurdles to actually getting people evidence-based care.
Absolutely. And there's so many things that are evolving. Because when I first started doing telemedicine, I was like, how am I going to do this? Like, someone's calling me for this and that. So I had to rethink how I'm addressing them. I'm visually seeing them, rethink how I ask questions regarding symptoms. And it was good for me. It expanded my mind. It actually really made me think about the physical exam a different way. So it was really very good. But well, then I'm going to end this podcast real quick so I can ask you this question offline. Well, thank you everyone for listening. And thank you so much, Dr. Brewer, for spending time with us. Is there any bit of, and of course, I'm going to put links to everything, the Craving Mind, everything, all the apps. And I always like to ask, is there one bit of advice you would like to send to someone, maybe someone who's struggling with an addiction of any kind? It could be shopping, it could be eating, it could be smoking. What would be the first bit of advice that you would give to someone who's even just beginning to open their mind to change?
That's a great question. I think I would simply say, whatever that behavior is, pay attention as you do it. Look at the result. Look at that cause and effect relationship, because that's the beginning of behavior change. Just pay attention.
That's awesome. Excellent. Well, thank you everyone for listening. And again, please click all the apps or the links below and you'll see everything that you need.